Hi, this is Dr. Deepak Megur. He is a 60-year-old gentleman who has this long-standing hypermature cataract with a fibrotic capsule, question mark, and underlying calcified plaque. I'm not sure about that. The reason for delaying the cataract surgery was a patient who has had an heart surgery done. He's on warfarin and the cardiologist was not giving him fitness, and so there's a reason why the surgery got delayed. And nevertheless, now he's posted for surgery, and the challenge is really to deal with the anticapsule in this patient. Of course, we have a dense underlying cataract. So in all these long-standing cataracts, we have issues with the anticapsule, we have issues with the zonular health, and also we'll be dealing with the slightly denser nucleus. So let us see how things turn out here. The actual fibrotic area is delineated only when we stain the anticapsule. Now this is the picture which is staring at me, and the area of fibrotic capsule is extending all the way up to the mid-periphery of the anticapsule. So that is a worrying sign, because as it enters the area of zonular insertion, you're controlling the capsulotomy tear is going to be difficult, and there is always a chance of it extending up to the equator. The other point which I am considering is I want to know whether the underlying plaque can be dissected out from the overlying capsule. If that is so, then we can dissect out the plaque and then the secondary rhexis could be initiated. So the plan is to first try to do a smaller rhexis. If it is not possible, then I'll have to use a scissors or a cutter to cut all the fibrotic areas. So as I try to puncture the anticapsule, we can clearly see that it's extremely thick and tenacious. I'm unable to perforate. So I'm using the lateral cutting edge of the bent 26 number needle itself to cut across. And I'm trying to cut the overlying capsule, but I could feel that the underlying calcified plaque is also getting cut along with it. So the idea is to use the sharp edge of the bevel of the needle to make incisions into the capsule. I'm trying to make a circular one. At this point, I thought there was a cleavage plane between the underlying plaque and the overlying capsule. I resort to my forceps to just try to convert it into a small rhexis. But I was unlucky in that the other part of the underlying plaque was truly adherent, and it was very difficult for me to separate the anticapsule from the underlying plaque. I'm trying to use the forceps to grab the underlying plaque if it is possible, but unfortunately it is very much adherent to the overlying anticapsule, so I'm unable to dissect out the plaque here. Using a 23G curved micro scissors through the side port so that I have a direct access and a good angle to cut, I'm cutting the capsule along with the underlying plaque. I'm trying to make the cut as circular as possible, and once I see that some of the area is devoid of any fibrosis, I'm trying to resort to again going with my forceps and trying to initiate a tear beyond the area of the fibrosis. But just a few clock hours later, again I hit a roadblock where the underlying fibrotic band is extending all the way up to the equator. So again, I can't proceed in this area with the forceps. So I thought that let me come from the other way around. Again, I'm using the scissors to cut the fibrotic capsule in the opposite quadrant. A flap is raised and ovary is again replenished into the eye. Now using the forceps, I'm trying to negotiate the tear beyond the area of the fibrotic region until again I hit this roadblock where the fibrosis is extending all the way up to the equator and the tear is being uncontrolled and in fact going under the pupillary margin. Nevertheless, I could still feel that I had reasonable control over the tearing edge. I continue with the forceps and always trying to pull it in, and thankfully I could pull it inside, and eventually I had an extremely large capsular opening. The entire fibrotic area had been covered by the capsulotomy tear. Although the capsulotomy margins were irregular, it might not be ideal to call this as an rhexis, but still we had an opening which was reasonably safe for me to proceed with phacoemulsification. So with this large capsular opening, I decided to go ahead and start Nucleus Management. At this point, I needed to be mindful that these zonules and the posterior capsule will be compromised in this long-standing cataract. So I would want to avoid any stress on the posterior capsule during the nucleus division maneuvers. So these capsules are all pathological, so I need to be extremely careful and be mindful of that aspect. So in this case, I've decided to go in with the stop and chop technique. I feel this is much more safer. Now, since we do a very deep sculpting, the stress which is required to crack the nucleus is relatively lesser. So I'm just creating a depth which is almost 90%. Once I see the very thin posterior plate, which is seen by the change in the color, the dense brown color is gone and we can see a grayish color in the posterior plate. This suggests that the depth is almost 90 to 95%. So at this point, I stop sculpting, and this is the time to divide the nucleus into two halves. When you're trying to do lateral separation, it's extremely critical that both the instruments are kept as deep as possible in the groove, and then the lateral separation maneuvers are done, so that it induces minimal stress on the capsular bag. The settings are changed to the chop mode, and I'm going to use the longitudinal energy to bury my phaco tip into the nucleus and then divide it. So each heminucleus I'm aiming to divide it into 3 fragments. While chopping, care is taken to lift up the nucleus with the probe just a little bit, and then the vertical chopper goes in down and then laterally. So this maneuver ensures that we're not pushing down at the posterior capsule during the chopping and the lateral separation maneuvers. The nucleus is rotated using bimanual maneuver using the phaco tip as well as the chopper to move it around, and then the vertical chopping and lateral separation maneuvers are continued. Once the nucleus division is done, settings are changed to the quadrant removal mode, wherein I'm going to use just the torsional energy to emulsify the fragments. In a controlled manner, all the fragments are emulsified. Now is the time to deal with the cortex. Just a little bit of cortex is remaining, and which is taken care by the bimanual I&A. Time to implant the lens. The bag is inflated with OVD, and the planned single piece lens is placed into the bag. So OVD both in front and behind the lens is aspirated out, and that's it, the case is done. These are the first day post-op pictures. To summarize, this patient had challenge in the form of a capsule which was difficult to manage. It was a fibrotic capsule and it was extending all the way up to the equator in certain quadrants. So if we have a smaller area, then we can always make a capsulotomy around it. But in this case, because it was extending all the way to the periphery, it was challenging. A combination of using micro scissors at different areas and then using forceps to tear the capsule in the healthy zones. This was the combination which was used, which eventually gave us a very large capsular opening, but it did the job. And care has to be taken while managing the nucleus because these bags are extremely thin and flimsy. So there's always a risk of damaging the posterior capsule. Using a technique so that the nucleus division is very controlled and very gentle in the bag is critical. So that was it. Thank you for watching and hope you found this helpful.